Hello, everyone. Can you hear me, especially Orla?
I can. Can you hear me?
Good. Well, it's right at 3:30, but I propose to wait just a few minutes for people to navigate the password and to react to the news that they're being recorded. Uh, Monique, I see that you're on. Thank you for helping to set this up. In the future, if there's any way we can do it without a password, I hate passwords, but I don't mind if they are recorded since I think we're recording our live sessions anyway. But it's up to you, Monique. Thank you for setting this, our very first Zoom Scientific Seminar Series meeting.
You're welcome.
We have a number of people continuing to sign on. I see a count of 21 already. So my first question is answered. Will anyone call in? Apparently a number of people have. 24 and counting. '27, '28. All right, so we're up over 30, which is a good crowd. So thank you everyone for joining us. I hope that you can hear me. I want to briefly just make a few announcements and introduce Orla, and then we'll let Orla take it away. So we resisted as long as we possibly could, but even I have accepted that we're not returning to the normal world anytime soon. So for the next foreseeable future, we're going to try to have these Center for Aging scientific seminars conducted remotely by Zoom. And Orla Sheehan has agreed to be our very first Zoom speaker for the COA Scientific Seminar Series, so I appreciate that. We do have an opening for November 2nd, I believe, is an open date. So if any of you who are listening, and especially those of you who are perhaps a little more experienced and have experience with our center and our seminar series, if you want to volunteer to take November 2nd, that would be a great deal. Adam Spira has agreed to do the December 7th talk, and we already have a couple commitments for 2021. So we're in pretty good shape, but do have that November date still sitting there open for anyone who would like to grab that opportunity to tell us about their research in a sort of structured 1-hour scientific seminar presentation. But today we're fortunate to have Orla Sheehan. And again, most of you I'm sure know Orla. She's been with us now for about 6 years. I was checking over the email records, and we hired Orla in a research associate position in 2014. Prior to that, she had received her training in internal medicine and also in geriatric medicine with a strong dose of neurology and stroke work as well in Ireland, in Dublin, Ireland. And I think the bulk of that, or perhaps not all of it, occurred at Mayo University Hospital in Dublin, Ireland. But around, I think, 2013, she moved to the Baltimore area along with her husband and family, and they both made it their mission to connect to the Johns Hopkins community and become faculty members here. We hired Orla in a research associate position in 2014, and she quickly impressed virtually everyone with her can-do attitude and her multiple skills in conducting science and writing and conceptualizing and even analyzing data for research. A very multi-talented person, which, as you know, those are the kinds we prefer here in our Center on Aging and Health. She was quickly promoted into a regular tenure-earning faculty position as an assistant professor in 2016. Has received a lot of funding, mostly as a co-investigator for her work in aging and in caregiving and in stroke and in geriatric medicine and home health care. Has made a number of very valuable collaborations. I think it was probably, about a year, maybe 2 years ago, that we formally promoted Orla yet again with no raise, but more responsibility as she became the director of our linked administrative data resource. So when you hear about the cold room and ladder and how great it's doing, that is at least 90% due to Orla's leadership and her, and she's the official director of that subunit within COA, if you will, for the last at least year, probably 2 years now, I'm sort of losing track on time on that. But anyway, Orla, we're thrilled that you're at Hopkins. We're thrilled that you agreed to give this presentation, and I'm going to turn it over to you. The title of your talk is Caregivers, What's New and How Do We Engage Them Virtually? Looking forward to learning something about that. So take it away.
Thanks, David, and thank you for the lovely introduction. And for inviting me to do the very first virtual scientific seminar here at COA. I just want to check, can everyone see my slides and can everyone hear me? Okay, I'm getting a thumbs up from Brian. I have turned off my email, so if anyone needs to communicate at any point, Zoom chat is probably the easiest way. I've left that open in the corner, but if anyone notices questions along the way that I haven't seen, feel free to unmute yourselves and interrupt me. It's hard to do this virtually for 90 minutes, so I think we'll take a few breaks along the way, and I'd encourage anyone who has questions to just unmute yourselves, let me know, and we'll do our best to answer them. So as David said, I'm going to talk to you today a little bit about caregivers. I have no disclosures relevant to today's presentation. So we're going to initially start off talking about the role of informal caregivers in the lives of older adults. Then I'm going to move to discuss caregiving and its effect on health and use the caregiving transition study to share some great work that's been done over the last 2 years. Then, in view of our current changing research landscape, I'm going to hopefully share a model for success for engaging patients and caregivers virtually by shifting to a completely different project that I worked on over the last year. And then we'll hopefully end with some discussion about where will we go next for caregiving research, especially in view of the current pandemic. So excellent work by Jennifer Wolfe and her co-authors have taught us that about 15 million family caregivers assist older adults with daily activities for both health and functioning reasons. And informal caregivers provide about 80% of all long-term care services. Many people just think of nursing homes when they think of long-term care, but most of the people receiving long-term care in our community are at home with the support of informal caregivers, usually family members. And this is a huge economic value each year, somewhere between 400 and 500 billion. Unfortunately, the ability of informal caregivers to meet demand is threatened. Our older population is growing, but despite this, we have smaller and more dispersed families. It's quite normal now for children to live in different states or even overseas, and with COVID, restrictions on travel are allowing less support to happen. There are fewer non-working adult children in families, and this is all coupled with an increasing emphasis on home-based care. So a lot of care is moving from the hospital to the community setting, which is great for the patient, but we can't forget about the burden that places on caregivers. We also have very little information so far on the impact of COVID on availability of caregivers. I've heard lots of anecdotal reports, some saying there are more caregivers available because more people are working from home. Others are saying caregivers who didn't live with the person are less able to help with that person because they don't want to put them at risk by entering their home. So it's really hard to know what COVID is doing to the availability of caregivers. So we know these caregivers tend to be family members, friends, or neighbors, and they provide regular ongoing assistance to a person because of a disability, mainly adult children and spouses. But I just want to start off by saying that not all caregiving is the same. And if we think there isn't one uniform definition for a caregiver, and this can provide some challenges for research. So if you imagine, if you have a son who lives in Delaware, who comes to Baltimore 3 or 4 times a year and takes his elderly mom to her PCP visit and to her cardiologist, he would self-proclaim himself to be a caregiver to his mom. But he would also be in the same bucket as somebody who provided 24-hour-a-day care to their wife who was suffering from advanced dementia. And I think for many reasons it may not be appropriate to compare the caregiving duties of those two individuals. We also know from a lot of research that dementia caregiving is associated with longer hours of care and often places a greater burden on caregivers. We have to remember that about 70 to 80% of people with dementia live in our community with a caregiver, and without those informal caregivers, our rates of institutionalization, especially for conditions like dementia would exponentially rise. So many of us have seen lots of reports, both in media and in literature, on the health effects of caregiving. We've heard and read reports of increased anxiety and increased depressive symptoms because of caregiving. Physical effects, things like raised blood pressure. Changes in social determinants of health, more loneliness, more social isolation. We've also heard of direct effects of caregiving on blood biomarkers, things like C-reactive protein leading to increased inflammation and increased cardiovascular risk. The challenges with many of these studies is that they are convenience samples and very few are population-based. And these convenience samples often recruit perhaps a non-representative sample of the caregivers you're looking at. If we think of maybe caregivers of persons with dementia and who are recruited from a specialist dementia clinic, the people who attend a specialist dementia clinic are often people with unusual symptoms, unusual diagnoses, and often people with a lot of behavioral problems, or perhaps who are, their families are educated and can self-refer to these services, but they often don't reflect people living in the community with dementia as a whole. Control groups are often poorly described, and when they are described, are sometimes not well matched to the caregivers. Controls often tend to be almost super healthy volunteers, which come from either recruitment through advertisements in clinics, or they come through maybe volunteers at senior centres, and often aren't matched for socio-demographic or health variables to the caregivers. I mentioned earlier the difficulty with definition of caregiving, and many caregiving studies don't even define what they mean by caregiving. So you have people providing a variety of care all in the same caregiving group. So we're going to, with Monique's help, I'm going to ask you to click a poll and tell me if you think that caregiving affects mortality. And Monique, whenever you want, you can go ahead and share the poll, and there'll be 4 responses. Yes, caregiving makes you die earlier. No, caregiving makes you live longer. We don't know, someone should study that. Or it depends on what type of caregiving. So if everyone could please click an answer and then press submit. And I'll give you about 20 seconds to do this, and then Monique will kindly share the answers with us. I think we can end the poll, Monique, and show the results. Okay, so great. Most people have responded, it depends on what kind of caregiving. About 13% say caregiving makes you live longer, about 13% say we don't know, and only about 6% feel that caregiving makes you die earlier. Okay, so let's see. So thank you to, I think the poll just relaunched, Monique. I'm just going to shut it down. Thanks to David for letting me share this slide that highlights the US Administration on Aging position that caregivers suffer a mortality rate that is 63% higher than non-caregivers. I just want to break this down. So this came from the study, let me see if I can annotate this. There we go. This came from this study here, Schultz and Beach study from 1999. And as you can see, the overall study didn't have a significant effect, but when they looked at spousal caregivers who reported being under a lot of strain, under high strain, they had a mortality rate that was 63% higher. You can see that 5 subsequent population-based studies failed to replicate this finding, the most recent of which was done by David Roth and others using the regards data. And here in blue, you can see the caregivers. In the thick black line are propensity matched non-caregivers. So a group of caregivers that were very closely matched for socio-demographic and health variables. And then the dashed line is all caregivers, so the non-propensity matched caregivers. And you can see after 8 years of follow-up, an 18% reduced risk of death compared to the non-caregivers. And looking at subgroups of race, age, caregiving relationship, and caregiving strain also failed to show any mortality effects. So on the background of this, David Roth was the, I suppose, brains behind the caregiving transition study. And what this is a longitudinal outcomes of health effects of caregiving study. And really what it wanted to do is look at the effects on health of becoming a caregiver. So usually I will put acknowledgement slides at the end, but I just wanted to start with this, especially in COVID times. So this was our Caregiving Transitions Project group retreat that we had, almost 18 months ago now. And this is us all eating in Fells Point. One or two people were missing, so I photoshopped in Jeremy. But you can see this collaborative group coming from the University of Alabama, Birmingham, from Vermont, from the University of South Florida, Chelsea Liu has since left us for Harvard, and a number of different investigators here in Johns Hopkins. So for anyone who's not familiar with the REGARDS project, it's the reasons for geographic and racial differences in stroke. And it's a longitudinal epidemiologic study of stroke incidence that began recruiting in 2003 and enrolled over 30,000 persons 45 years and older. You can see this graph shows where all the REGARDS participants lived, and you can see there's a deliberate oversampling of the stroke belt, the southeastern US states that had the highest stroke incidence rates. There's also an oversampling of African Americans. So 53% of the cohort were white and about 57% were women. And at baseline, all REGARDS participants were asked this question: are you currently providing care on an ongoing basis to a family member with a chronic illness or disability? This includes any kind of help such as washing your family member, dressing or bathing this person, arranging care or providing transportation. And at enrollment into the REGARDS study, about 12% said yes they were, and about 88% said they weren't. And then 10 years later, the people who had said no at baseline were asked the same question. And if they answered no at baseline and yes at follow-up, they were deemed to have transitioned into a caregiving role, and they were eligible for the caregiving transition study. And this just shows you the timeline for caregiving transitions. So because one of the things we were interested in was the effect on blood biomarkers of becoming a caregiver, we really anchored this study between the two REGARDS in-home visits. So when people were recruited into REGARDS, they had some baseline computer-aided telephone interviews, and then they had an in-home visit where a number of different health markers were assessed, including a blood draw. And then about 10 years later, they had that visit repeated with a second blood draw. So we wanted people who, between those two time points, became caregivers. And here you can see how we came up with, it's a flowchart really to show you the population that we recruited into the caregiving transition study. So we started off with about 13,000 people who did the computer-aided questionnaire, and about 1,200 of whom had become caregivers between the baseline and follow-up interviews. And of those, about 546 were potential caregivers, and they were contacted, and 251 of them were enrolled. During those steps, people were excluded if they weren't providing sustained caregiving. So we didn't want people who, maybe looked after mom for 4 weeks after her hip replacement. We wanted people who were providing sustained, ongoing caregiving. We also set a threshold for caregiving. These people had to be providing at least 5 hours of care per week. So the gentleman I described who was taking his mom to PCP visits would not have qualified for this study. They had to be providing regular, ongoing care. And using the rather large pool of non-caregivers, we then performed very strict matching to get a control group as closely matched as possible to the caregivers on 10 different sociodemographic and health variables. So unsurprisingly, because they were matched, there were no differences between the caregivers and controls on sex, race, education, marital status, age, self-rated health was similar. No difference in cardiovascular disease, in the duration between assessments. And if you go back to the REGARDS baseline, when all of these people were recruited, There were no differences between caregivers and controls on depressive symptoms measured using the CESD scale, on perceived stress, or on quality of life measured using the SF-12 scale. These groups were very well matched. So one of the first things the caregiving transition study did was do a systematic review of the literature looking at the association between caregiving and immune system functioning and inflammation. Because caregiving has been proposed as a chronic stressor that can lead to negative impacts on inflammation and immunity. And particularly from an inflammation point of view, it's been linked with cardiovascular disease. And after doing the systematic literature review, we then went on to do a meta-analysis of effect sizes. And after trawling the literature, we found 30 database papers for inclusion, from which 42 immunity effects and 46 inflammatory effects were extracted. And here are the results. So this is for caregivers versus controls. You can see combining the results of the 30 studies, there was a small overall effect size of 0.16. But I also want to point out that if you look at the 3 population-based samples, they all crossed 0. So none of them were significant. So after doing that, we then went ahead to look in the caregiving transition study and see what the effect on biomarkers of inflammation was on transitioning into a caregiving role. So we were able to look at the change in these 6 biomarkers over a 10-year period. So we looked at IL-6, interleukin-2, interleukin-10, C-reactive protein, TNF-alpha receptor 1, and D-dimer, and found that only TNF-alpha receptor 1 showed an increase in caregivers compared to controls. And again, the size of this one effect was very small, 0.14. And we feel that this, combined with the results of the literature review and meta-analysis, challenged the widespread belief that caregiving is a substantial risk factor for increased inflammation. So just conclusion on caregiving and biomarkers. So as we saw, most studies are based on small convenience samples. Non-caregiving controls are often poorly characterized and differ from caregivers on recruitment and other selection factors. And convenience samples often analyze many biomarkers. A number of the studies we looked at 10 or 15 different biomarkers and overemphasized, we feel, the 1 or 2 positive findings that they had, and almost cherry-picked the results. We found no prior population-based studies that found significant biomarker differences between caregivers and controls. And when we looked in the caregiving transitions population-based study, we also found little change from before and after the transition to caregiving in the same person. Okay, so that's biomarkers. I'm going to stop for 1 second. I'm just looking at the chat. Does caregiver relationship have an impact on the health of the caregiver, spouse versus children? So, Ravi, if you want to unmute yourself, in relation to which? I am going to go through that in a number of different findings around well-being. You mean specifically in biomarkers?
Yeah, all dimensions. Yeah, biomarkers, other survival, comorbidities, other kinds of things as well. And also whether you, when you compare them, do you adjust for this as a potential confounding variable? So when you compare caregivers to non-caregivers or other kinds of things, is this something that's important to consider?
Definitely, and it's something that we have looked at in most of the analyses we've done. I'm going to come to that in a minute around social engagement and around caregiver well-being. But certainly for the mortality effect, no, it didn't differ by caregiving relationship.
Or by the, Ravi, to add to that answer a little bit, so, you know, the caregivers and the controls are sort of matched on demographics, including marital status, and but when we've looked at relationship, and in the biomarker literature, it really doesn't matter. These are sort of overall caregiving effects that are not modulated by spouse versus non-spouse. Or also go back, you know, so the poll question was great. Everyone gave answers. You know, I picked the caregiving makes you live longer, although I would argue a little bit with the wording about that. I think there's a good literature that caregiving is associated with longer longevity, whether the caregiving itself is the causal factor responsible for that. I think that's where we need more research to be sure. So that answer is both right and wrong in my opinion, but I picked it anyway.
I was just trying to keep it as slightly controversial and simple as possible, just to try and break up our Zoom life a little bit.
Yeah, sounds good.
And Melissa, I saw your question as well. I'm actually going to come to this in a few minutes because I absolutely agree with you. Self-efficacy and, you know, thinking about this stress caregiving model is actually a really good way of framing this, and I am going to come back to that in a second. So caregiver well-being. So we're all familiar with the body of literature showing caregivers having higher rates of depression and anxiety and lower scores and indicators of quality of life than non-caregivers. Again, the magnitude of some of these differences can be hard to accurately measure, mainly because a lot of these studies use cross-sectional comparisons of convenience samples. And as I mentioned earlier, the caregivers are often drawn from these high-stress environments like support groups or specialist clinics, and controls are often super healthy. So Bill Haley at the University of South Florida, one of our co-investigators on this project, led this work looking at caregiver well-being, and again looking at the 251 caregivers in transitions and comparing them to the 251 controls. A reminder, these are persons who began substantial sustained caregiving. And what he found was a marked worsening of psychological well-being compared to carefully matched non-caregivers, with a relatively smaller worsening of self-reported physical health. 1 second. Okay, so how about social engagement? And Chelsea Liu, who is kindly able to join us today from Harvard, looked at social engagement and its relationship with caregiving. So again, we know from the literature that social engagement is associated with improved caregiver well-being. Similar issue with use of convenience samples. We know very little about social engagement in subgroups. How about dementia caregivers, spousal caregivers? So what we did in this project was we examined the effect of social engagement on transitioning into a caregiving role and looked at the effects of sex, race, age, and different subgroups on this social engagement. And here is what was found. So on the left, you can see the change in social network scores over the 10 years, and on the right, the change in monthly social contacts. And you can see that social network scores and monthly social contacts for both caregivers and controls declined over the 10-year period. Let's see if we can annotate this again. But you can see the social network scores decreased by about 1 unit for caregivers and about 1/3 of a unit for controls. So decreased for both groups, but about 3 times the increase for caregivers and controls. And the monthly social contact scores decreased by about 1/2 a unit for caregivers and 1/4 of a unit for controls. So about double the effect for caregivers and controls. Interestingly, caregiving for persons with dementia was associated with less decline in social engagement. I wonder if this is perhaps because there's a larger network of people taking care of the person, you've more perhaps paid caregivers or outside help coming in. This definitely warrants further study. Also found that each additional hour of care provided was associated with greater decline in social engagements, which is not terribly surprising. And Ravi, another point of view is spousal caregivers here also showed a greater decline in social engagement. Again, I'm presuming perhaps social engagement is often, linked to your partner. So people, if the care recipient wasn't able to engage as much, perhaps the caregiver will also hold back from social engagement. Looking at satisfaction with social activities, lower satisfaction was reported by caregivers reporting high strain and those providing more hours of care. And higher satisfaction was reported by older caregivers, which was interesting. So now I'm going to look at one particular subgroup of caregivers, dementia caregivers. And we saw that of the 251 caregivers enrolled in the caregiving transition study, about 117 were dementia caregivers and 134 were non-dementia caregivers. So for the next few slides, I'm not comparing caregivers to controls. I'm comparing dementia caregivers to people providing care for conditions other than dementia. And these groups were quite well matched. So the dementia and non-dementia caregivers were similar for gender, race, education, marital status. Dementia caregivers were about 3 years older than non-dementia caregivers. They were also providing care for people who were about 4 years older. They were providing more hours of care a week. Dementia caregivers provided about 50 hours of care compared to about 38 hours provided by the non-dementia caregivers. Caregiving duration was the same, about 6 years for all of our caregivers. There were no differences in caregiving relationship between the two groups of caregivers. And you look at caregiving strain, you can see the dementia caregivers were almost more than twice as likely to report being under a lot of strain. About 37% of dementia caregivers felt they were under a lot of strain, compared to about 16% of non-dementia caregivers. And this is coming back to Melissa's point. So for looking at this analysis, I chose to use the stress process model of caregiving to look at stressors, appraisals, and outcomes. So think of stressors like objective stressors, things like the number of hours of care you're providing. Appraisals are really objective. Sorry, did I say subjective? I meant to say for stressors, objective. Appraisals are subjective. So how something makes you feel, how difficult you find something, what burden it places on you. And then for outcomes, again, objective health measures, things like number of depressive symptoms, your score on a quality of life outcome. So first we'll look at the stressors. And you can see dementia caregivers almost across the board report more stressors than non-dementia caregivers. They report dealing with more ADL and IDL problems, unsurprisingly more cognitive problems and disruptive behaviors. What I really want to emphasize here is look at the total number of problems they're dealing with. So dementia caregivers are caring for people with about 19 problems, compared to non-dementia caregivers who are caring for people with about 12 problems. So 7 extra problems is a huge amount to be dealing with. And when we look at their appraisals of burden, there was no doubt that they had higher appraisals of burden. They reported more difficulty with ADL problems. So for each individual ADL problem they reported, so just say they reported a bathing problem. We then asked them on a scale of 1 to 5, how difficult is that problem for you? And dementia caregivers, even for the same bathing problem, found it more difficult than non-dementia caregivers. They also had more difficulty with cognitive and emotional problems and disruptive behaviors. They reported higher treatment burden. And this is basically the burden of all the things they're being asked to do for their care recipients' health, whether that was to keep track of their medications and give them their medications, bring them to appointments, coordinate their care, give them nebulizers twice a day. The number of things they had to do was more burdensome from a treatment point of view for dementia caregivers. They reported higher caregiving stress, as we saw earlier, and more perceived stress. And then if we look at some of our outcomes, you can see dementia caregivers showed a trend towards more depressive symptoms. No real differences on quality of life using the SF-12, but on self-report, they were asked, do you think caregiving has worsened your health? And again, about 33% of dementia caregivers felt it had, compared to about 15% of non-dementia caregivers. And they also were far more likely to report that because of the strain they were under, that there was a delay or health tasks didn't get done for the people for whom they were providing care. We then did some modelling on this, and we created 2 models. One, accounting for the age of the caregiver and care recipient. If you remember, dementia caregivers were older and were providing care for older individuals. And the first model also adjusted for the hours of care per week, which were higher in dementia caregivers. And then in our second model, we accounted for the same 3 things, but added in the total number of problems. If you remember, dementia caregivers were caring for people with about 7 more problems than non-dementia caregivers. And a spoiler alert before we look at the tables, the first model had little or no effect on measures of burden, but controlling for the total number of problems explained many of the differences between these 2 groups of caregivers. Here you can see the appraisals of burden we spoke of earlier, and in red you can see the unadjusted effects we already described. And then when we account for model 1, which adjusts for the age of the care recipient, the age of the caregiver, and the hours of care. Very few changes. But when we add in the total number of problems, we explain almost all of the differences, with the exception of the cognitive and memory problems, which is unsurprising when we're comparing dementia and non-dementia caregivers. And then for the self-reported questions where they reported that caregiving worsened their health, again, controlling the total number of problems removed these effects. So what have we learned about dementia caregivers? So they definitely provide more care and report higher burden. They deal with more problem behaviors, ADL and IDL impairments, strain, perceived stress, and treatment burden. Their care recipients are more functionally impaired. The care recipients have twice the memory problems and disruptive behaviors and more than 6 additional problems. We found that differences in burden could be explained by adjusting for the total number of problems. So I think it's important to reduce the overall volume of problems that someone is dealing with and to target interventions focused on specific issues. Dementia caregivers were more than twice as likely to report a subjective worsening of their health because of their caregiving. Although the focus is on dementia caregivers, I think it's really important to remember that 15% of the non-dementia caregivers also reported being under a high strain. So although dementia caregivers are a really high-risk group and one that deserve all of our attention, we can't forget that other caregivers are also burdened and need to be focused on. So that was pretty much a tour de force of some of the work we've done in the caregiving transition study. And I think, especially over the last 3 or 4 months, we've managed to really move the needle in this project and get out some really, really great papers, which I was delighted to share with you. I hope you'll agree this is a rich data set of instant caregivers and matched controls. There are lots of areas of future study in this work. We definitely need to be more cognizant of caregiver well-being. But I think as a final point on this, I think we need to remember that as demand for caregivers rise but supply falls, we, society, our healthcare system, we need to acknowledge caregivers as the valuable resource that they are, target supportive interventions appropriately, or we're just going to face rising institutionalization and soaring healthcare expenditure. Remember, most persons with dementia and most people requiring care are cared for in the community. They're not in institutions. So if we don't address this, and if we don't put caregiver well-being as a focus of healthcare policy, then we're going to face soaring healthcare expenditure. Okay, I'm going to stop there and happy to answer any questions about the caregiving transition study or any questions about any of the data that I presented.
Hi, Orla. That was really wonderful. This is such a rich data set. Thank you so much. I did want to ask about a buffering relationship, like if you've looked at any interaction terms, particularly around stress and some measure of strength, whether it's self-efficacy or purpose in life, meaning, because there's some interesting research at a UCSD, their psychiatry department, looking at caregiver burden and self-efficacy, particularly coping self-efficacy, particularly problem solving. And that when you look at the interaction between burden and self-efficacy, it actually buffers inflammatory cytokine IL-6. So it's a small study, but it's fascinating to think about. We have stress, right? But then, and we have to, the first primary appraisal in Lazarus and Folkman is this stressful? Yes, it is stressful. Then the secondary appraisal is, can I handle it? And so it's kind of like, if you look at the interaction between, is this stressful and can I handle it? Sometimes really interesting things. I'm just curious what your thoughts are on that.
No, I completely agree. I'm pretty sure there's a threshold, and depending on varying things, and I think self-efficacy is definitely one of them. Some people have a higher threshold than others, and some specific things push people over the edge more than others. Unfortunately, we don't have a self-efficacy measure. What we do have, and we haven't looked at, is we have personality questions. which may get to it in a certain way. We haven't looked at the personality questions in relation to the dementia compared to non-dementia caregivers, but that is a really interesting point and one we can definitely look at. At
Melissa,
any
I'll
point,
just-
yeah,
I'll just
I was
jump
going to say,
in
at
too.
any point here, as David's PI of the study, he's very welcome to interject.
Well, we have purpose and life measures, and we have positive aspects of caregiving measures, and
Okay.
and I think some of those moderator questions that you laid out are things that we've planned to do and anticipate doing, but we have only peaked at this point. We certainly haven't gone through a systematic in relation to any of the outcomes, biomarkers or depression. So welcome your increased involvement in that if you
Yeah.
want to get involved in the thought group that sort of leads that those set of analyses.
Sure.
This is incredibly rich data set, and I think we've only really started to lift the lid on what we have. There was a big focus to try and get all the data collected, and really in the last few months we've done, I think, a great job of trying to delve into it, but there's so many more questions we can explore, and I think that's a great one.
Okay.
Thanks, Melissa. Any other questions? Sorry. Let me I'm just reading the chat. I think it's interesting how dementia caregivers thought their health was worsening, but biomarkers may not have supported that. Yes, definitely. The difference between self-report and objective measures, exactly what Melissa was just alluding to, whether it's an appraisal or an actual objective measure. Also makes me wonder what could be used to measure these concepts. Again, I think some of the discussion we just had is very relevant there. Physical biomarkers or psychological measures of stress. I think it has important implications for research, as stress should perhaps be more of a holistic concept measured in several ways. I completely agree with all of that. Stress is just a really hard concept because it means a different thing to different people, and that can be very challenging. You know, it's almost like the caregiving definition. There kind of isn't a uniform definition of what people mean by stress. So I think in any of these studies, it's important to specify what we mean. Okay. Unless there are any other questions, I'm going to give everybody a 2-minute quick break, just to feel free to grab a glass of water, a cup of coffee. Do not check your email or leave the building. I'm just going to stop for a minute or two to give everyone, it's really hard sitting down on Zoom for 90 minutes. So everyone stand up, move around, do whatever you want, and I'll call you back in about a minute. Okay.
Orla
So-
couldn't resist. I peeked at email, and Ravi Vardhan has just sent us both an email with some references about potentially extending this, including the complexity of the care recipient. One of the papers he's attached is apparently by Monica Safford, so it would be a
Oh,
really
great.
good paper. So
Yeah, sorry, I deliberately turned off my email, but I will look at that later on. Great. So when I did a talk on Friday, and I showed a 2-minute timer, and it was kind of funny. We realized that everybody stayed staring at the 2-minute timer, so I didn't show that YouTube timer today, only because I actually wanted people to take a break. Okay, we're going to change tack completely and leave the caregiving transition study aside, and I just want to talk to you about something completely different. Some work I did last year before the COVID epidemic was even thought of on engaging patients and caregivers virtually, and I thought it had some really nice lessons that we hopefully can use for our research going forward. So as we're all beginning to see more and more publications in the literature around the effects of the current pandemic on caregiving and caregivers. The first article here reports an inevitability that caregivers will pay the highest price during this crisis. We've also all heard anecdotal clinical reports of people being under a lot of stress. They may previously have allowed paid caregivers come in and relieve them from some of the burden, give them a break. They may have other family members coming in, but people have really tried to limit the number of people around vulnerable older adults to try and protect them. So I think caregivers are definitely under increased pressure and increased strain right now. There are other studies going the other way, and this lower study shows how caregivers are really enjoying telemedicine and video visits, and feel that they can communicate well with providers, and don't have to bring the person into a clinic. Obviously, there's lots of things that are missed by telemedicine. It can be very useful in certain circumstances, but I don't think I entirely agree that it is the solution. So what I want to talk to you about today is some PCORI-funded work that I did in collaboration with Bruce Leff here in Hopkins and Christine Ritchie, who was at UCSF at the time and is now in MGH in Harvard. And what we wanted to do was engage the invisible homebound and their caregivers in the development of a home-based medical care research agenda. So before I can tell you what we did and how we engaged these people, I need to do some level setting and make sure that everyone is familiar with the homebound population. So this is Irene. Irene is typical of the invisible homebound. She is an absolutely lovely 88-year-old woman who has had several strokes. She is aphasic, so can't speak because of one of her strokes. She has dementia, heart disease, diabetes, and arthritis. She's mostly bedbound. Her amazing 65-year-old daughter retired 2 years ago to provide her with 24-hour care 7 days a week. They're just over the income for Medicaid home services, so the daughter is pretty much on her own and caring for her mom. She hasn't seen her primary care practitioner in 2 years, but they're fortunate that the PCP still refills meds over the phone. Really, she hasn't had longitudinal care in about 4 years because for the 2 preceding years, she struggled hugely to get to the PCP office. So Irene's healthcare runs in sort of cycles. Something tends to happen, usually difficulty with her breathing. She has increased shortness of breath. The daughter's not sure, is it her heart failure? Is it a chest infection? They muddle through for a few days, and usually they have no choice but to call an call an ambulance and bring her to the ED, where her daughter describes she often spends most of the day. She gets a few IVs. If it's an infection, she gets maybe 2 doses of antibiotics and comes home on oral antibiotics. Sometimes they can hold things off, sometimes things improve, but more often than not, 3 or 4 days later, they end up back in the ED by ambulance. She gets hospitalized, stays for 5 or 6 days, then ends up in a skilled nursing facility for a while, and then comes back home to the daughter with skilled home health care coming into the home for a month or 2, and then everything goes back to normal. And what the daughter feels is a waiting game, just waiting for the whole cycle to repeat. I think everyone will agree that Irene has really high healthcare needs, and the cost of her healthcare is also extremely high, and really negatively affected by her lack of access to primary care. So people like Irene are among the costliest patients to our healthcare system. So another poll question for you. And Monique, you can go ahead and launch the poll whenever you're ready. But what I'd like to know is, how many homebound individuals are there in the United States? Are there 25 million, 2 million, 200,000? How could we possibly know? Are there 7 million, or does it depend on your definition of homebound? So if everyone wouldn't mind picking a response, I'll give you another 10 or 15 seconds and then we'll have a look at the responses. Okay, Monique, I think we can close the poll and see what people said. Okay, 43% said it depends on your definition, and that is true. About 17% said about 2 million, about 30% said 7 million. No one thought 200,000, and about 10% thought 25 million. Okay, so anyone who said 2 million B, 7 million E, or depends on your definition, I would call all of those correct answers. And I'll tell you why. So this is work that Catherine Ornstein has led using the National Health and Aging Trend Study data that really has delineated the epidemiology of the homebound. So you can see that she found about 2 million people are homebound, about 400,000 of whom are completely homebound, and about 1.5 million of whom are mostly homebound. And mostly homebound is rarely went out in the last month, so went out less than once a month, and completely homebound is never went out. And although there are 2 million people who are homebound, there are another probably 5.3 million who are semi-homebound, so can never leave their homes without assistance or without difficulty. So there's probably somewhere over 7 million people in the US who are either completely homebound or semi-homebound. And the second graph, I'm just going to annotate this again. In this figure down here, what she did is she followed the population from 2012 forward 6 years through the waves of NHATs to see what happened to these people. So the beige fawn box here or area are community dwelling people, and you can see they decreased over time. The brown wedge at the bottom is mortality. So obviously more people died, about 24% died over the 6-year period. The yellow or the orangey yellowy strip is the nursing home population, and that stayed pretty consistent throughout the 6 years. And this blue wedge here is the homebound, and you can see it increased by 13% between 2012 to 2018. So that's equivalent to about 4.5 million people in the population who became homebound over that period of time. And in the same period of time, 1.2 million moved to a nursing home. I think it's really important for us all to remember and to have as our baseline that there are about twice as many people homebound as there are in nursing homes. And I think, when we're asked to think of vulnerable groups in our society and especially in our community, we think of the homeless, those with intellectual disabilities, mental health disorders, we think of those in nursing homes. But I challenge you all to include the homebound when you sort of make a list of who are the most vulnerable groups in our community. And let me just move away. So let me just stop the annotation. There we go. So homebound older adults, we've said, are high need and high cost. And I think the description I gave you of Irene nicely illustrated that. These people have multiple chronic conditions, they're functionally impaired, they've limited social capital, and they have huge access issues. What I wanted to show you in this graph, and this is Medicare spending, but it really shows nicely how people can have multiple chronic conditions, and the green bars show your chronic conditions. Let's just annotate that again. Okay, so here you have 1 chronic condition, 2, 3, 4, 5, and you can see spending increases with increasing number of chronic conditions. But if you look at these red bars, these are people with chronic conditions and functional impairment. And you can see that pretty much any functional impairment exponentially rises your healthcare costs. So the real challenge here is these people are functionally impaired. And I also just want to point out that most homebound older adults cannot access any form of longitudinal primary care. There's a lucky group of people, about 10% of them, who are able to avail of home-based primary care. So doctors or advanced providers who come out to their homes and provide them with care in their homes. And something like the J-home practice we have here in Hopkins. And we know that if we provide care in the home, it dramatically improves lots of things for these people. It decreases their ED visits and hospitalizations. It reduces their days in hospital. It reduces admissions to long-term care. It reduces bed days in long-term care. It reduces costs. And perhaps most importantly, it improves patient satisfaction and caregiver quality of life. So home-based primary care works, but most people who are homebound do not have access to it. So now I want to come back to what we actually did and what was the work that we wanted to do. So I hope I've convinced you that homebound older adults are often an invisible, vulnerable population who haven't had a voice. I challenge you to think of any research trial that has included a subgroup of homebound older adults, or any research, in general. I have to say, over the last few years, there's been a huge increase in the amount of research that's been done in this population, but it's still minuscule compared to other vulnerable populations. So we really wanted to help them develop a patient and caregiver-centered research agenda for the field. Oh, sorry, there was a question in the chat, was that just physical function or physical and cognitive function? And I think that was referring to this graph here, and it's actually just physical impairment in activities of daily living. So you can only imagine what it would do to costs if you put cognitive impairment into that graph. Great question. Okay, so what we wanted to do in our PCORI project was establish a patient and caregiver-centered research agenda for the homebound in the short term, but really in the long term, come up with a sustainable approach for involving these people in research in the field. So the project had 4 aims. First, we started off qualitatively talking to people because we really wanted to develop some tactics to recruit, train, and engage stakeholders as partners in research. We then wanted to develop an advisory group using homebound patients and caregivers, and we did this bi-coastal. We had one group in San Francisco and one here in Baltimore. We then engaged with our advisory board and we developed a homebound stakeholder advisory research agenda, and then we disseminated this work nationally. So I love these 2 pictures because I think it really illustrates nicely the difference between East and West Coast meetings. So this research group, pre-COVID, used to meet in person every few months. And on the left, you can see us meeting in Henderson's Wharf and Fells Point, and on the right, a meeting in La Jolla, just outside San Diego. And when I looked back at these 2 pictures, one seemed far more formal than the other. So the first thing we did was spoke to 30 stakeholders to really get their views and experiences of being either homebound or caring for someone who is homebound, and how they feel about the research process, and some strategies that they may be open to involve them as research partners or advisors. So we spoke to 13 homebound older adults and 17 caregivers. The group, about 40% were dual eligible, over 70% were women, and almost 60% were non-white. Did someone want to ask a question? I heard someone unmute themselves. I'll keep going, but feel free to interrupt if you have a question. So from talking to them, the major themes that emerged, firstly around attitudes to research. So most of them viewed it as important and an opportunity to learn and share knowledge. One person remarked, we need these opportunities, to learn from and to teach others. They felt research was very relevant to them. They felt it could impact them. It would be very educational and helpful to the new caregivers coming in. It might not fix me, but perhaps it could fix someone else. When we talked about the roles they could potentially have in research, most reported interest in advising researchers. They were really excited by this, but many of them expressed fears about having the ability to communicate. A lot of those fears stemmed from, the fact that they were homebound. A lot of people said, if I could get out, I'd love to help, but, how could I help you? And some people said, I'm no expert, and am I the only one going through this? I'm not sure there are many other people in my position, which was absolutely untrue. And many people said things like, if I could be of any help, I wouldn't mind. We then had long conversations with them about how we could best engage this group in research. And most of them said they would prefer to use the telephone. We talked to them about in-person meetings, about using conference call type systems, about one-to-one phone calls, about using video conferences, around multiple different permutations of those options, which I'll talk about in a minute. And really, it came down to people were happy with the phone and had very limited openness to trying other things. So then we stepped back a little while as a research group, trying to figure out what on earth to do next. And we came up with sort of 4 options for how we could go forward. We felt in-person engagement would be ideal, really for relationship building, because we really wanted to build a sense of community in these people. And we thought we could see body language, we could see, how comfortable people were discussing things, how distressed certain things made people. But unfortunately, we're pretty convinced that in-person meetings were impractical for this population. If these people can't even leave their homes to get to a primary care visit, there's no way we can bring them in for research purposes. We agreed with them that phone was very reliable, people were familiar with it, it would work, and it was cheap. But we felt it was a little bit impersonal. We really felt it would be lovely to be able to see them in some way. We thought about video conferencing, which we thought was far more personal and better for community building. But when we talked to these people, we found very low IT literacy in the population we spoke to. I think only 2 or 3 people in the population owned a computer or tablet. About half of them owned smartphones, but only about half of those actually knew how to use them. Video was going to be very costly because we would have to provide devices, and there were some security concerns, which I'll come back to in a minute. The fourth option we came up with is kind of a hybrid model where we would get research assistants to go into the homes and help facilitate joining a meeting via Zoom or some other video conferencing platform. This was labor intensive, and we still had the same connectivity issues of being in people's homes and requiring data plans, and we also felt it would be very costly. We tried to keep, I suppose we're trying to weigh up a few things. We wanted something that was sustainable, and we knew that there were going to be cost implications in this, and we really wanted to think first of the best way to engage this population and then try and figure out a way around the costs. But we were challenged because we knew that we could throw some money at this for a pilot, but if we wanted this to be more sustainable in this population, we really couldn't have, extortionate costs. So now, I want you to put yourselves in our shoes, and knowing all that, what would you do next? And Monique, we can go ahead and launch the third poll, please. So what do you think we should try? Should we only have an advisory group of caregivers where we can bring them in person and not have not have any homebound patients as our advisors? Should we do a hybrid model, bring the caregivers in person and sit in a room with us and send research assistants out to the homes of the homebound patients and allow them to connect to the same meeting? Should we do everything over the phone, or should we try and use a virtual platform for both patients and caregivers? Okay, I hope everyone has had a chance to give their answer, and Monique, we can go ahead and close the poll. Okay, so a little bit more of a mixed response. So I think about 40% felt hybrid, about 48% said try a virtual platform, and about 20% said a phone. And I'm delighted that nobody thought that we should exclude the caregivers. Okay, so here's what we did. So we went with the 48% of you, and we decided we would try and make a virtual platform work. So I suppose our major concern was if we had caregivers in person and if we had patients over video, the people in the room are more likely to be engaged than the people over Zoom. So we really felt it wasn't a fair engagement of this group if we kind of did the hybrid model. We honestly were really worried because we thought that the whole thing could fall flat and we may not achieve what we had promised we would do for PCORI, but we thought it was worth trying to use a virtual platform. So we deliberately told our program officer what we decided, which kind of committed us, and then we moved forward to look at devices. So we started off looking at iPads and tablets, which were really expensive and would require data plans. And I suppose one thing we didn't anticipate is we ran into IRB challenges. What we hadn't considered was the issue with what would happen to these, would Johns Hopkins have liability if somebody inappropriately used these devices? If, for example, they downloaded pornography or ran up some huge gambling debt logging into the internet from these devices, which was something we honestly hadn't anticipated when we were making our decisions. So around this time, we became familiar with GrandPad, and this is one of the things I wanted to share with you today that I think definitely is useful in our new virtual world. And over the last 6 months during the COVID pandemic, many people have asked me about this project, which is the reason I decided to share it with you today, because they know how positive I've been about our experience using GrandPads. So GrandPads are a different type of tablets. They're completely programmable. They have an inbuilt data plan. What was great for us for research is we could rent them. And so we didn't have to buy them, which really cut our costs. And they're designed for older adults. So they have large buttons, very clear instructions, and they have amazing customer support. So this is what the tablet looks like. And this was programmed specifically for our study. So you can see there are only 3 buttons here. On the left, study info, Zoom in the middle, and on the right, help. So if you press the study info button, a very quick blurb about our project. And if they clicked on that green call button, that connected through a Google phone number to one of our 2 research assistants. So that call goes directly to them. So one tap call to us. Again, if they press the help button, they get GrandPad customer support. I just wanted you to look at what they say here. Call me with any questions or just to chat. So I now know of a number of different situations in which these GrandPads are being used to augment clinical care. And it's for people with social isolation or people who are lonely or people who are, especially during this pandemic, I know of one instance, a person who's attached to the house call practice in UCSF who literally calls GrandPad almost every second day for a chat. And these people are absolutely lovely and they're more than happy to facilitate that. And this is an example of one of our meetings, and a few people chose not to have their faces visible. So in case you're wondering why there's some black screens. So I'm going to quickly tell you what we did and then share some of the lessons learned. So we conducted 8 meetings, 15 really. We did 7 with each group in Baltimore and San Francisco separately, and we brought everyone together for one group at the end. So we really started off building community, and in each of our meetings we started off with 10 or 15 minutes of community building. And then we started trying to see what were their ideas around research and what things they felt should be researched for their population. So we asked, what do people not understand about your or your loved one's needs? What do you wish your doctor could help you with? And they came up with really good ideas, and we kind of, I suppose, roll those up into domains or buckets that we felt were important. Things like out-of-pocket costs of caregiving or specialist care in the home. And under each of those domains, then, we encouraged them to formulate research questions. And it was incredible what they came up with. For some of these domains, they came up with 30, 40 research questions. And then they prioritized the domains. They prioritized the things they felt were most important to study first. So our Baltimore group came up with this list here, and I won't go through them all, but things like challenges faced by caregivers, specialist care in the home, importance of home-based care. A huge one was out-of-pocket costs of caregiving, patient and caregiver well-being, access and policy change. And these are the topics identified by our team in San Francisco. And we encouraged each team to name themselves. And I love the San Francisco names. They came up with the Home Care Optimizing Team, or HOT, which they like to be referred to. And the list they came up with was caregivers not being understood, challenges of receiving care outside the home, again, specialist care and access, delivery service, home being the best place to be, and relationship with doctors. And then we led them through how to come up with research questions. I would say this was, I think, one of the most fun projects I have ever done, and also the most challenging in lots of different ways. Translating and maintaining the patient and caregiver voice was key to this work. We took frantic notes, we recorded things and transcribed them, but we also wanted to make sure that we were capturing the essence of what they wanted to say. So after every meeting, we came up with bullet points, and we sent the information by mail back to the caregivers and to the homebound patients, and we asked them to look through it, and we essentially gave them highlighters and red pens to correct our mistakes and to really make sure that we captured the meaning of what they were trying to say. Recruitment and retention were very challenging in these groups. People got frail, and people had to miss meetings, so we deliberately over-recruited so that we had a larger group than we felt we needed. I think one thing that was a real lesson You know, PCORI has some great language around advisory boards and teaching people about PCORI and patient-centered outcomes research and comparative effectiveness research. These were real patients. As I said, these patients would not have met the criteria for most clinical trials. And our population really struggled with PCORI language. And I have to say, after our first meeting, we put that language aside and we really wrote our own language and our own explanations for these concepts. I'd say easy tech isn't necessarily foolproof. Even grandpads were challenging, and I'll come back to that in a minute. The US Postal Service was far more challenging than I ever anticipated. We had issues with, we were giving gift cards to the people each time we sent out the notes from the meeting. And we had one paid caregiver coming into a home who unfortunately was stealing one person's mail. Another person was unable to get to their mailbox to collect their mail. Another person, a caregiver had moved in with their mom and their mail was being redirected, which made that there was like an extra 2-week delay in the mail reaching them. Another challenge was moving from people drawing from their personal experience to considering broader issues affecting the field. Many people had had negative interactions with varying healthcare services, experiences with short stays in nursing homes, and really impactful, powerful experiences that they wanted to share, which were extremely beneficial to us to hear. But over time, we were able to move to sort of considering broader issues and how might things affect other people in your situation and not just you. And then one really surprising thing was the therapeutic benefit we found from this work and knowing when to stop. So we initially planned 6 meetings, but actually, so one challenge we had was, these are a really vulnerable, frail population, and we were very, very careful not to overburden them. And we initially thought, we'll block an hour, but let's try and talk for about 30 minutes. And literally from the first meeting, everybody asked, can we stay on longer? We've more to say, we want to talk more. So we kind of used the hour. And then after a few meetings, they asked, could we extend to 2 hours? Now, we kind of capped it at 90 minutes because we felt that it, even if they were enjoying it, that there could be negative effects on them for, if they tried to keep going for 2 hours. And really, we planned 6 visits, planned 6 meetings, but they had so much more to share that we continued for 8. And even after we had finished, they shared contact information among themselves. They became their own support group. It was kind of incredible to watch. And so just because of so many of you are now trying to use virtual technology, I wanted to share quickly some of the lessons we learned. And I'm happy to talk about this, either afterwards or through email. But definitely simplify and test any technology before you send out the devices. Remove any extraneous applications. There's ways you can make Zoom much more simple than the platforms we're using right now. You can completely reduce the number of taps required to start a meeting, and that's what we did. Great thing about GrandPad is they can remotely program things to all the devices. So when we found something easier, we found a problem, they could apply that to all of our participants remotely without them having to go in and do anything. Prepare to have to give lots of training in different ways. So we gave written materials, we did some in-person training, which obviously wouldn't be practical right now. We connected via landlines, cell phones, via the grandpads themselves, via grandchildren's iPads, whatever was needed to try and teach people how to use these devices. Have backup plans. Don't try and run everything yourself. You need multiple people to do this. We had 4 people at any one time doing this. One person, 2 people on tech, one person watching the chat, one person leading the discussion. And you can never provide too much support. Another thing I loved about GrandPad was we could remotely see if the devices were charged. So we called people a few days before each meeting to remind them to charge their GrandPad, and we could see if they actually did it. And if they didn't, we could call them back the day before and ask them, can you please plug in your device, and we could see if the charge was increasing or not. They also had a GPS location device, which was incredibly helpful when one person accidentally, they were admitted to hospital and ended up in the skilled nursing facility, and somehow or other their GrandPad ended up with the sheets that were being cleaned from the room, and we were actually able to locate the GrandPad somewhere in the skilled nursing facility. And we designed our meetings to foster really a sense of community among participants and researchers, and that proved to be incredibly important. And then obviously, one of the critical steps in this was disseminating our work. So we got the advisors to rank the importance of the ideas they came up with, but we also convened a national group of researchers in the field, and we asked them to rank the ideas. And nicely, the sort of both groups prioritized the same things. And we obviously submitted a report to Corey. Here's one of our recent publications on the therapeutic value of being involved in a stakeholder engagement project for homebound older adults. We have 3 other publications currently under review. And the one thing I would say is I would love people to use this as a call for action. And if anyone is interested in doing research in this population and wants to know what these people feel is important to study, please do contact us. And almost all of our advisors have been willing to stay on in other capacities. 2 of them have been recruited to a national learning collaborative to improve the quality of home-based care that we are running, and are definitely open to other research efforts. So for some final takeaway messages before we open it up to discussion. So virtual engagement is definitely possible. It's hard, it's definitely not easy, but I feel it's ideal for hard to reach populations or in the current pandemic. You know, I've also seen reports of virtual technology working well in rural populations. And really, if you think about who's not really involved in typical research studies and who you can't get to, consider if it could be useful for them. It's definitely labor intensive. It decreases over time. I have to say by meeting 3 or 4, we had very few technical problems. But, you know, up to then we were joining 20 minutes early, 15, 20 minutes early, and we were talking to people on cell phones through technical issues. I could not get over the enthusiasm of this group, their willingness to try things, and the incredible information they're willing to share with us. So I think the absolute take-home message is these people have a really meaningful contribution to give, and we need to engage with them and harness that. And that's the end. So any questions or comments? And I'd also love to know how many of you have adapted your work to engage patients and caregivers during COVID. I see Karen is also a fan of GrandPad. It's funny, I know a number of people in our division across Hopkins who use these devices with older parents and very successfully. I showed it set up for a research, I suppose, audience, but it can also be tailored to exactly what you want. You could have like an equivalent of FaceTime where they could call you. You can have a call icon connected to numbers, and you could have photographs of, you know, different family members that they could press and call. You can have an area for where they can look at photographs, and you can upload photographs for them. And there's lots of different things you can do to tailor these devices. And GrandPad, I have to say, certainly from our experience, were extremely easy to work with. Catherine Clare is another question. For future research efforts, would it be possible to send the notes summaries which were mailed through GrandPad? That's actually something we hadn't explored, because obviously when we did this, it was, you know, set up with mail, and what we actually did when mail wasn't working, our research assistants kindly delivered some of these things to patients' homes, which I know isn't necessarily possible right now. I definitely think we could. It would obviously require another icon or, you know, putting another button on the screen, but these are so, you know, these can be customized, and we absolutely could have a way of sharing information over the GrandPad. Costs. So it depends on the project. It depends on how much programming you need, how many devices you need, things like that. But I think we paid for about 400 for each of these devices to rent them for a 9-month period, which we thought was extremely competitive, and we were very happy with. It certainly would have cost us a lot more to buy iPads and to get data plans for that time period. So I'll open it up to any questions, or feel free to just use the chat and I can call them out. I know it's the end of a long day, but I'd love to know how other people have adapted things during this time when it's less possible to bring people in person? And, you know, have you just switched to questionnaires over the phone, or has anyone else tried to use video conferencing platforms?
Hi, Orla. This is Katie Marks. I can tell you what we've done in the ADS Plus study that Dr. Roth is on, and it's Adult Day Services Plus. It's it's a nationwide study. So all along we've been doing our surveys over the phone. So that didn't change. What did change was that the intervention was being done by the social workers or nurses at the adult day where the person with dementia went. And it was a caregiver intervention, and so we had to switch to everything either being by phone or by Zoom. And we offer it either way for the caregiver, whatever they're more comfortable with. It seems that, like you said, most of them were more comfortable with phone than Zoom, but some of them became much more comfortable with Zoom as we went along. I definitely would love to talk to you offline further about some of the things you found because of different studies that we've been thinking of on our end.
Yeah, everything we did was pre-COVID, so we absolutely were doing it in a different research environment.
Yeah, everything is completely different, but we're definitely looking into some more virtual means of spreading some of the work. So
I was curious. So even, you know, I happened to be talking to last week with one of the group who were involved, and it sounds like, because they've set up their own network, so they're in contact with each other, but it sounds like really because of COVID, most of these people have either learned to use their smartphones or gotten smartphones for the first time or gotten some sort of a device, because otherwise they weren't able to communicate with their other
a lot of them the caregivers have learned how to use Zoom and become much more comfortable with it because that was the only way they could connect with grandkids and things like that.
Mm-hmm. That's exactly
when it becomes necessary.
Yeah, and I think, you know, it's also great to see, like, all the people that we did this with knew not one of them had experience with video conferencing technology, and within 4 meetings, everyone pretty much had it down.
Yeah. How did the people did you have the people they were caring for on there also, and did any of them have dementia? How did they do?
So yeah, so we definitely had caregivers of people with dementia. We borrowed Sarah Zanton's kind of capable dementia level. You know, there were people with mild to moderate dementia, but everybody had to be able to give informed consent and understand what we were doing and feel comfortable taking part. Honestly, during one of the meetings, it was very obvious that one of our participants was delirious. You know, these are a very vulnerable group and they get sick very easily, and cognition is one of the ways in which that manifests itself. And thankfully, we were able to very quickly link them into their house call service and intervene very quickly. So it was quite fortunate that they happened to be on the meeting with us that day. But yes, some of our people do have cognitive issues, but they are all able to consent to participation.
Okay.
But cognition fluctuates.
Right.
It's a challenge.
Yeah.
I have to say, anyone that, you know, with cognitive issues, we did our very best to also recruit their caregiver, or at least consent them in the presence of their caregiver, so that, you know, there was a group understanding of what was going on. Challenge is about 60% of this population have cognitive impairment, and to automatically exclude all persons with dementia doesn't give a true flavor of this population and doesn't share their experiences.
Right.
And just because people have, as you know, just because people have cognitive issues doesn't mean they don't have very valuable things to share with us.
Exactly.
If anything, we should prioritize getting the information out of these people when they can.
Orla, this is David. I got a couple, I guess, questions or comments for you. And this is really for the group, not so much for you, Orla, but it strikes me that this is, getting homebound patients and their caregivers involved and participating in sort of the thinking about research and the priorities of research is, I think, fundamentally the interest of this grant. And it's a type, I guess, of community-based participatory research. And I'm wondering, in the age of COVID, there must be all kinds of scrambling to engage communities in community-based participatory research, since face-to-face meetings are rare and risky. And I imagine some of these same issues of big phone conferences versus Zoom calls and other ways to keep the community or get the community engaged in these times are challenges across a whole broad band of community-based participatory research. So I'm wondering if anybody's on the call today who's tackled that in other populations, or if that point makes sense in terms of applying it to this particular group.
I'll stay quiet for a second. Anyone have any thoughts on that? Anyone experienced that? I do anecdotally know from some conversations we've had with our program officer in Corey. She mentioned that some of the usual avenues for community-based participatory research weren't available, certainly in the early days of COVID. Senior centers stopped operating. Some of the usual methods they had weren't available to them. So I think a lot of people were doing a lot of scrambling early on, and I think a lot of, and completely understandably, research took a backseat to the priorities of making sure these people weren't socially isolated, that they had food, that they had healthcare. So I think a lot of these organizations shifted their focus temporarily, but I am beginning to see more and more sort of research coming out from community groups recently.
Right. I guess the comment I was going to make too, and this is more a suggestion about a bridge between your sort of two active areas of research. But I think you mentioned early on that in the caregiving literature, we compare dementia caregivers and non-dementia caregivers, and different relationship categorizations. We have all these categories of caregivers, but yeah, I can't remember really any studies that have specifically asked if their care recipients are homebound. And it sounds like that's something that I think you're suggesting, that this be important contextual distinction that we start measuring, maybe even routinely, in studies of caregiving, if they're caring for someone who's homebound, and what that might mean in terms of additional challenges, especially to get them adequate care. I would imagine would be one of them. And it strikes me that through the NHATS study, we can perhaps even start studying already some of the differences between caregivers of homebound and non-homebound patients. And maybe you or Catherine or others have already done that. But I think this is an important distinction that can certainly get more traction in the caregiving literature for sure.
Yeah, and I'd extend that to, I think, every epidemiologic study should ask about people's ability to leave the home. Because I think, if you don't ask about it, you just assume, and possibly incorrectly. I'm not sure if you're aware, but Regards have also added that to their question batteries. So certainly for transitions, we are going to be able to figure out if people were homebound or not through, by extracting the Regards question.
Well, for the caregivers themselves, but not for the persons they're providing care for.
True.
But you might help us craft the one magic sentence, or maybe it's 2 or 3 sentences that you ask a caregiver to determine if their care recipient meets definitional criteria of homebound.
A few people have sort of asked similar question. What I have suggested is really copying the NHATS wording as much as we can, so that we can compare similar things across different groups in the population. But happy to.
Well, we're 1 minute away from using the full 90 minutes. It's been a great informative talk, Orla, interesting, and some data and some future direction. So I thank you for doing this. I don't want to shut down the discussion. If anyone else has a burning question to ask now, get it out there. Not hearing any. I'm going to wait for about a day or two for a volunteer for the November talk, and then I'm going to start approaching people individually with at least down on one knee, if not both knees, asking them to commit to taking November. Adam, I see that you have signed on. Thank you for committing to doing it in December. And we have a couple speakers already lined up for 2021. So if we get that November slot filled, then at least we have a pretty full docket going forward for a few months. So thank you for being on this, the very first virtual Center on Aging and Health Scientific Seminar Series. And we'll be in touch about who we get lined up to speak on November 2nd at the same time, 3:30 on Monday.
And last word of thanks to Monique for doing a fabulous job with the polls and all the tech behind this.
All right. Take care, everyone. Bye.
Bye-bye, everyone.